So we're going to continue on here and move to the objective evaluation and the objective portion of the injury exam process. And so it's important to look at this and remember that this is a component of the systematic exam, right? And we're looking at this point specifically to try to find objective data. The subjective exam obviously focuses on subjective data. This is going to be objective data, which are going to rely on measures that are readily reproducible. This is what we're looking at when we consider the objective examination, as things that can be easily reproducible regardless of who's conducting the evaluation. And so a lot of these are very controlled with regards to very specific techniques that you need to do with each one. So these are going to be described in the literature somewhere. And so then you reproduce them according to the same technique that they did. And then that way, when you document them, everyone knows exactly what was done and exactly what that means. And in that case, it serves as a communication tool between practitioners because we can know exactly what occurred with regards to what each of these tests mean. If we had everybody using their own special tests and the like, we would get to a situation then where we would not know what exactly was occurring. It's also important to remember with all of these that this is part of a medical record and are legally required to do that. Another area to consider when we're looking at the objective examination is the role of the non-injured limb. And basically with this, anything that you do on the involved limb, you should also do on the non-injured limb, thereby providing a reference with that. So you perform each task on the uninjured limb first and then on the injured limb second, thereby allowing for a situation where we have a decreased apprehension level because the individual knows what to expect with what you are going to be doing, and it will allow for a better test. It will also allow you to more readily compare the injured and uninjured side, knowing what is normal for them. So in these charts here on this slide and the next, we specifically look at the segment of the examination as well as then what the role of the non-injured limb is. So at the same time, while we focus on what the role of the non-injured limb is, we're also going to be reviewing the different components of an exam. So it starts with the history, and with this, the non-injured limb can also help us establish pre-injury health baselines, but we can also use it to replicate the mechanism of injury. Sometimes it's helpful to be able to move the uninjured limb or to ask them to move the uninjured limb and describe what has occurred from the mechanism of injury to the primary complaint. Also with that, in the functional assessment component of the examination, we can use the uninjured limb to help provide information regarding how specifically the condition is impacting the patient's ability to perform their variety of tasks with that. Moving along into more of the objective measurements side, the inspection, it gives us a reference for symmetry and alignment. Palpation, again, we're looking for alignment, tissue temperature, and densities with that. These are the things that we're going to be palpating for, so we can look for abnormalities. With the joint and muscle functional assessments, we give references to their available range of motion and strength. Same thing with joint stability. We can get a reference for their end feels as whether they are typically hyper or hypomobile individuals. The selective tissue tests that we get in there as well, these will serve as our reference for the various pathologies associated with that, and same with neurological and vascular screenings. You can see basically all of these come down to the uninjured limb providing us a reference. So it's always important throughout our injury evaluation process to use the uninjured limb as that reference. Another thing to consider when we're looking specifically at the evaluation process and the clinical assessment is to understand what the difference is between a more clinic-based assessment and your more on-field evaluation. And specifically from that point of view, that a more thorough, complete clinic-based assessment is going to be much more comprehensive, whereas the on-field or acute evaluation is specifically trying to first rule out life-threatening conditions, and then second, look at things that can possibly be made worse through movement of the athlete. Eventually, right, the on-field evaluation is going to give way to a more clinic-based assessment that can focus on making diagnoses and treatment decisions. As well, in that sort of thing, it's important to consider everything from the patient-centered focus in there, right, including informed consent with that, but also the importance of understanding what the athlete is important and treating them as a patient. And that brings us back to the ICF model, right, and the different things that we looked at within the ICF model. So in our examination, remember, our goal is to rule out differential diagnosis and determine that clinical diagnosis and our assessment for what is wrong, but also to move beyond that with the impairments and functional limitations. Also, within this, it's important to keep in mind that our standard precautions against blood-borne pathogens are still relevant with that. So looking at the overall function and the overall map now of our examination, we've talked already about history in previous lessons. Now we're going to move on to the objective evaluation that traditionally includes our observation or inspection, palpation, special test, and then to our assessment. But don't forget, during this entire process, we're also looking at creating that problem list, identifying the causes of each of those problems. Then we would assess goals that address each of those causes, and then therapeutic interventions that assess those specific goals. So keep this entire component in mind. We're just specifically going to look at this part right here in this lesson. But we already talked about history and subjective examination, and in more of the treatment advanced courses, we will focus more on this bottom part. But remember, this is really all one specific examination. So we'll start with inspection. Inspection is simply going to be our observations that we see with regards to what is occurring. We immediately are going to observe any changes associated with the initial injury, whether that's changes in gaits or posture. You might also be able to see some functional changes associated with that. Being on site in that practice with that, you might be able to see that they're starting to compensate in their function on the field or playing surface. You might also then, after an injury, see that their guarding or muscle spasm might be associated with that, or splinting techniques, which is simply the body's way of preventing motion. We're also then going to be looking at our more physical exam observations, again always comparing bilaterally. We're looking for deformities, either subtle or gross deformities, as far as things that are completely out of place that might give us an indication of what is wrong. Swelling, right, both edema and bruising or hemarthrosis aspects there can get into play with identifying where things are wrong. In inspection will also be girth measurements. This can be anything from measuring swelling to measuring muscle mass, right, and comparing bilaterally to see if there is increases in, joint girth that would indicate swelling, or decreases in muscle girth that might indicate atrophy associated with that. We also assess the skin for redness, signs of infections, as well as ecchymosis or more bruising there. Within that, also, we have the functional assessment in our inspection. During that, while they're performing functional tasks, we will be identifying different impairments that might occur with that, or compensations associated with that. So the inspection process occurs right after the subjective examination or the history, and in which case we're again trying to narrow it down more by looking for and looking at the area of chief concern. Next, move on to palpation, right? And this is a diagnostic touch with that. And we'll see that there really are two sequences associated with that as far as how you go about using palpation. Some individuals focus on creating a systematic approach where they're going to palpate all structures in the body region regardless of potential injury sites, where they start away from the injury site and move towards that. Others have a more specific approach to their palpation, where you're going to focus on bones, then ligaments and muscles and tendons, but specifically in the area of potential problem. And we know the area from our inspection as well as our history. But when we're palpating, we use lighter touch and then progressively deeper touch, so we can start to feel for things like point tenderness, trigger points, any change in tissue density, crepitus, or grinding, and then the tissue temperature. And you can see here some of the possible causes in the changes in tissue density with things like that. So abnormal feelings within the tissue can be associated with different causes. And so most of the time when we think of palpation, we're thinking of point tenderness, where we're trying to identify the specific structures through our understanding of anatomy, trying to understand the specific structure that is injured. And it makes sense that injured structures, when you palpate them, are going to create more tenderness. But we also can get a lot of information from changes in the tissue density, as well as what things might be occurring during that. Next in our systematic approach is joint and muscle function assessment. And so this is where we come, and it's really important in this area that we come back to this idea of reproducibility. And so when we think of muscle testing and range of motion testing, it is really easy to fake some of these and reproduce it yourselves. But in fact, the problem with that is, if individuals are not performing these in the same way, we cannot reassess them between patients, and we won't be able to understand what these are. And so there are entire textbooks, and this is one of the most common textbooks that are in there. All right, and it's by Florence P. Kendall. It was the first one, then other authors. And so when we do a lot of these sorts of things with muscle testing, we will often document that as, it was a positive biceps femoris manual muscle test, all Kendall, meaning according to the way Kendall described it in the book there. And so we have these different components of joint and muscle function, and we will look at those individually in the order that we normally do this. We start with active range of motion, unless it's contraindicated. And in some situations, you don't go through the entire evaluation process, because some times movements are not appropriate. But active range of motion is the motion that the joint can produce by the patient contracting their muscles. And so the importance reason for this is we get to see what motion is available without putting extra pressure on there that might cause injury. When we do this, we're noting how easy that motion was, the total range of motion. We also might see these painful arcs, but that's where goniometric measurements come into play, in the very specific technique to assess range of motion. We'll learn more about that later in following courses. But we're also looking at compensation patterns during that. We can then move to manual muscle testing. And manual muscle testing and resisted range of motion sort of thing can sometimes be used interchangeably. But you need to think of resisted range of motion is more strength testing in the cardinal plane, whereas manual muscle testing is going to be specifically described according to the muscle involved with that. They function fairly similarly with, stabilizing the limb proximally and applying resistance. And they're sometimes graded the same way as well. I prefer a resisted range of motion as a bilateral comparison in percentage, whereas manual muscle test is one of those things that actually is not compared bilaterally. It's compared against this standard here, where a 0 out of 5 is no evidence of contraction. So this is associated with neurological injuries there, where they are unable to even create a muscle contraction or muscle twitch. 1 out of 5 then is a patient cannot produce any movement, but you can see that contraction. 3 is basically the calling card with there that, at 3, the patient can move the body against gravity through the full range of motion, whereas 2 is they cannot move through that, but can through a gravity minimized position. So think of this, if you can move against gravity, gravity is a form of resistance. And so that is 3, you can go against gravity. But think of laying on your side and then raising your arm over your head in flexion, right? That is a gravity minimized position, right? Because gravity is not there. If you just were to support the arm there and just provide the gravity, they're not moving against gravity. And so if they could perform that motion in shoulder flexion, laying on their side, but not standing up against gravity, that would be a 2. 4 then is your typical resisted range of motion type assessment. So this is the only time that these are consistent. So if you have a 4 out of 5 strength, that means they can resist against moderate pressure. Whereas a 5 is they can resist against maximum pressure in this brake test. So 5 out of 5 there is actually in a specific position they can hold against maximum pressure. And so when we look at these sorts of components and understanding, it's important that we use these specific grading scales and describe that as well. So when we do a manual muscle test, right, we will see it's either positive or negative for pain, as well as the strength. Resisted range of motion can then be described out of a percentage with and without pain. Anytime we do objective evaluations, we're going to describe things both in an objective and somewhat subjective way, right? The quantity and quality of the test, right? So in this case, the quantity would be the strength measure. The quality would be with or without pain. We also then have passive range of motion, and think of passive range of motion as larger than just the same as active range of motion. We do in fact do the same sort of range of motion assessment, and that can be very helpful from understanding that if passive range of motion is greater than active range of motion, we can suspect muscular weakness with that. But if they're equal, we're looking at something more capsular in presence, because it makes sense. If we have muscular involvement, they would not be able to move through the same amount of motion as they can passively. But the static structures, capsules and joints and ligaments, are going to become taut and painful in the exact same position, regardless of whether it is active or passive. But in that same note, right, passive range of motion includes applying an overpressure to determine what we call the end feel. And the end feel then is going to be what feeling is imparted upon the clinician's hand at that end range of motion. And so you can see we have normal end feels depending on where things are, soft, firm, and hard, right? And each of those with specific aspects there. But then you also have abnormal end feels. And notice that some of these are described in the same sort of way. But if we have a normal end feel in an abnormal position, right, like a soft end feel that occurs sooner or later in the range of motion um, that is normal, that would become an abnormal end feel. And you can see some of the examples that that might be associated with. And the specific aspects of passive range of motion get into more specifics with joint stability tests. These are now when we do specific tests to address a non-contractile tissue. So like when we're trying to assess the ACL with the Lachman's test, right? That is a joint stability test, but it is also technically a passive range of motion test because it is passive in there. And we're looking for not only the quantity but also the quality of that. So we're looking for pain or the absence of pain, but also the quantity of motion. And when we have a firm end feel, but with a pain being present, that is our grade 1 ligamentous sprain. Grade 2 now is a soft end feel, right? Usually associated with pain. Then a grade 3 is empty, possibly without pain because you do not have a stretching of that because the ligament or joint capsule has been completely torn. We're also looking to assess, right? This is why we do bilateral with these, hypermobile or hypomobile. Sometimes there'll be a decrease in the amount of laxity. And laxity is that sign of give within the joint. So when you normally move a joint, right, there is what we call joint play, and that is the amount of natural motion associated with the joint. We should have not excessive, but normal comparatively, right? The ligaments are not going to be constantly tight. So if you were to go and do a Lachman's test on this knee here, and you would pull forward, you notice there's some normal joint play associated with that, and we would assess that bilaterally. Once we then get to the end point, right, then we would continue to pull, right, and feel what that end feel is. If we have a soft or an empty end feel, that is then instability, right? So we have normal joint play. And so when you're doing a ligamentous special test, you have to take it to that end point and then provide overpressure. And that's why those are associated with passive range of motion. We then have special tests, and these are tests that are specifically designed to stress specific and selected tissues. So they're unique to each structure. We compare those side to side, and some can cause increases in symptoms and some can cause alleviation in symptoms. And these are reported as positive or negative, right? And these can be similarly described based off of whether it's positive or negative according to what is expected from that result. Some special tests or selected tests, right, are positive or negative for multiple things. So you might need to say this was positive for instability or positive for pain, but it will describe specifically what is positive within each one. And sometimes the special test is similar in nature as far as the force being produced, but is specifically designed to select that specific tissue with that. And these special tests then have their own evidence regarding how effective they are at diagnosing those specific conditions. Next is neurological screening. With that, we have upper and lower corridor screening, right? Sensation, motor function, and deep tendon reflexes. We're specifically then going to be looking for nerve root or peripheral nerve damage that can be associated with a variety of different diseases. You usually do this then with your reflex hammer, and this is one of those specific reflex hammers that has multiple tools associated with it, the brush in the bottom and the pin in the top. So that way you can not only test deep tendon reflexes with the reflex hammer, but look to differentiate between sharp and soft touches. And we're specifically then going to be looking at where those abnormalities with neurological things are occurring. So nerves are mainly sensory or motor with that. Like we said, we also have the deep tendon reflexes that we can assess, but mainly we're looking at sensory and motor functions. We look then and we're comparing whether it's any abnormalities either in hypersensation or decreased sensation, and whether or not that's following a specific dermatome or an area that's innervated by a specific spinal nerve root that would say that the problem is within the central nervous system, or whether or not that problem is in a more peripheral nerve distribution. And so this is where light touch, sharp and dull discrimination, and then 2-point discrimination come into play, right? And in order to do that, you need to have them with their eyes closed and head turned away so that they cannot use their eyes for that. But you're going to ask for them to describe where they're feeling light touch, right, with the brush. Then you can use the bottom of the pin for dull as well as sharp and see if you can see differences bilaterally. And again, whether that is within a single dermatomal region or it's more in a peripheral nerve region. And then 2-point discrimination is the ability to identify whether 2 points that are near each other are felt as a single point or 2 different points with it. And so that's a higher level way to assess less damaged nerves is through this 2-point discrimination. With motor now, it's going to be done similar to our resisted range of motion with that, where we have specific motions that are controlled by specific spinal cord nerve roots. But in this case, we're going to see muscle weakness without the presence of pain, as well as muscle weakness with multiple muscles that are within the same nerve root. Right? So it wouldn't make sense for you to have multiple muscle strains all within the single nerve root, right? So that's where you would get pain, or you would get weakness without pain, because the muscle is not damaged. It's the neurological functioning that's associated with that. And so if you're unable to contract those muscles because you have a nerve injury, that would portray as weakness. And then the deep tendon reflexes associated with that. And you'll get more on all of this, of course, later. And then last portion of the objective examination is a vascular screening, where we're going to assess for blood flow to the extremities with that. We do that primarily through capillary refill of the nail beds, seeing if we have good flow all the way through the extremities, as well as the different pulses associated with that. And if we have weakness with different pulses, there's the possibility of vascular compromise. And then we always end, of course, with coming up with our diagnosis and then move through the rest of the process and ending with documentation. And so that is all for the objective examination. You will get all of this with specific components in additional coursework, but at this point I just want you to be familiar with the different components associated with the entire physical examination process. And so, as always, if you have any questions, please let me know. Otherwise, have a great day.